Indipharma welcomes you all doctors for the scientific webinar on sulfonylurea. Why do they stand today? From our renowned speaker, Dr. Pradeep Talwalkar, practicing at Raheja Hospital, Shushrusha Global Hospital at Mumbai. So I welcome doctor to start the session now.
Dr. Karande for introduction. We are going to talk about very important subject, the role of sulphonylureas in 2060. Where do they stand in the management of diabetes as on today? As you know, diabetes has affected 70 million Indians out of 415 million people all over the world, and the tsunami of diabetes is growing, it is not reducing. So why do we control diabetes? Why do we treat diabetes? What are our goals of therapy? The main goal of therapy is to reduce hyperglycemia and associated hyperlipidemia and hypertension to prevent vascular, metabolic and infective complications. 2/3 of diabetic patients die of vascular complications. The life expectancy of diabetics is about 10 years lower than the general life expectancy in our country, and that's why we have to control diabetes by effective management. And we need individualized approach. The key to management of diabetes is an individualized approach. Every patient is different, his needs are different, his reaction to the treatment is different, his complications are different, and he requires different therapy. The socio-economic status of the patient is also very important. Now, these guidelines have been set by this chart has been made by American Diabetes Association, stressing on the individualization. See, how do they individualize and how we should individualize in the management of diabetes. If the patient is committed, he is totally concentrating on his treatment, he wants to reach the goal, you set him very strict target. If he is young, 6.5 or even lower, up to 6. If he is middle-aged or around 67, I am talking about HbA1c. If he is elderly, between 7 to 7.5. But if he is careless, he doesn't take care of his lifestyle, he is likely to go into hypoglycemia, he is not committed, then in order to avoid complications of treatment, you set him little bit less stringent goals. Like in a young man, 7. In a middle-aged man, up to 7.5 HbA1c, and in elderly man, about 8. The second factor on which you will individualize treatment is his risk of hypoglycemia. If he is likely to have hypoglycemia, if he has suffered from several hypoglycemic episodes in the past, if he has a condition known as hypoglycemia unawareness. What is hypoglycemia unawareness? It is a condition in which patient does not have warning symptoms of hypoglycemia and straight away lands in serious symptoms such as convulsions, coma, abnormal behavior, and lands in emergency room. He goes into this situation because he doesn't have the advantage of warning symptoms of hypoglycemia, which we could have alerted him and he could have eaten. These kind of patients should have less stringent goals. They should have milder drugs. The duration of diabetes. Longer the duration of diabetes, the more likely he is having complicated comorbidities, the more likely he is having hypoglycemic episodes in the past. So these kind of patients should have less stringent goals. Life expectancy. Suppose a person along with diabetes has an advanced heart disease, or if he has a malignancy, if he is going to live for a longer time, shorter time, there is no point setting a stringent goal for him, because stringent goals help diabetics definitely, but over the long term. If you control his blood glucose tightly for years and years together, after 10-15 years, he starts reaping the benefits of good vascular control. But if he is not going to live up to that time, there is no point exposing him to hypoglycemias. So, less stringent goal in these type of conditions. Important comorbidities, say for example, severe heart disease. These patients should never be exposed to hypoglycemia. They should have HbA1c goals set little higher level. Established vascular complications, again higher HbA1c goal. And resources, support systems, if they are not good, again less stringent goals. So you set the goals as per the individual condition of the patients. These are the guidelines of American Diabetes Association. What do they say? The first drug is metformin. As long as metformin is sufficient to keep the patient at his HbA1c goal, continue metformin. When a time comes to add a second drug, you have a choice. You have sulphonylureas, you have pioglitazone, you have DPP4 inhibitors, you have SGLT2 inhibitors, GLP-1 analogs, and you have insulin. In our country, when the first add-on drug is considered, people generally don't like to add insulin because it is injectable. Similarly, GLP-1 analogs are also injectable and they are extremely costly, costing about more than 8,000 rupees per month only as for them. So our choice is usually limited between sulphonylureas, pioglitazone, DPP4 inhibitors and SGLT2 analogs. And there you will have to again individualize depending on what are you aiming at. I will come to this point later on. Now what I talked to you was the guideline of a Western advanced country. These are the guidelines, the latest guidelines of IDF, International Diabetes Federation, which has to cater to entire world, including developing countries like India and less developing countries in Asia and Africa. Look at this guidelines. What do they say? After metformin, as far as possible, the first add-on should be sulphonylurea. And if there are some special situations where sulphonylurea is not suitable, then you consider the other drugs, the modern drugs, which are far more costlier. So depending upon the socio-economic conditions also, sometimes you have to choose the product. Now these are the guidelines of SAARC country, India, Pakistan, Bangladesh, Sri Lanka and countries around our country. Socially, we are all similar. We are less developed, though India is the most developed among them. We are less developed as compared to Western countries. We are much more poorer as compared to Western countries. And last year, the endocrinologists of SAARC countries met together and they again emphasized that in SAARC country, the first add-on to metformin, sulphonylurea, should be considered first because of long experience of our doctors, because of their inexpensive cost-wise they are affordable, and because our patients seem to respond better to sulphonylureas. Recent studies from India and Pakistan report that SU-metformin combination is more efficacious than metformin DPP4 inhibitor combination in our countries and also more inexpensive, more suitable from socio-economic point of view. So, while deciding about what drug you will add to metformin, when the time comes for first add-on drug, you will consider various peculiarities of the patient, including his socio-economic status. In our country, for an average person who is not very well affording, who is paying from his own pocket and who doesn't have very serious complications, you may think of adding sulphonylurea. Why sulphonylurea? When sulphonylurea? And $1 million question, which sulphonylurea, after having decided that in an average person who is not very affording, we will start with sulphonylurea and metformin combination, the moment metformin alone is not sufficient. I already told you why sulphonylurea. Very inexpensive, everybody can afford it. Used for 50 to 60 years, all the doctors have handled these drugs, they know where to use it, what to do, when the complications occur, how to change doses, etc. When sulphonylurea? As I said, sulphonylurea should be used as first add-on when metformin alone fails. This is the most common indication of sulphonylureas. However, in a special situation, one may start the treatment of type 2 diabetes, the pharmacological treatment of type 2 diabetes with sulphonylureas. What are these special situations? Metformin is not tolerated by some patients. They get diarrhea, they get gastric upsets, and about 5% of the patients, even if you give metformin after meals, even if you give slow release preparation of metformin, even if you start with low dose and then gradually build up, these patients do not tolerate metformin. In such situation, in our country, in an average patient, sulfonylurea is the first line drug. Otherwise, sulfonylurea is first add-on drug. Sometimes you can use sulphonylurea as a second add-on drug. For some reasons you have added metformin and DPP-4 inhibitors, but the patient is still not at the goal because sulphonylureas are quite powerful in their ability to reduce HbA1c, which is better than DPP-4 inhibitors. In that case, metformin plus DPP-4 inhibitor or sulphonylurea is a good combination. For some reasons, say for example, patient who is very severely insulin resistant, you have added pioglitazone to metformin as the first add-on. But after some years, patient is not responding. So metformin, pioglitazone and sulphonylurea can be a good combination. Here you are using sulphonylurea as a second add-on. So the most common indication, first add-on to metformin, sometimes as a second add-on to metformin on the top of DPP-4 inhibitor metformin, or on the top of pioglitazone metformin, or on the top of SGLT2 inhibitor metformin. And in some cases as the first line drug if a metformin is not tolerated. So in other words, we have seen why sulphonylurea, because of vast experience, everybody can afford, and very high potency. When sulphonylurea, first add-on, second add-on, and in some cases as a first line drug. Now let us find out which sulphonylurea. So in short, before going into which sulphonylurea, let us summarize the plus points of sulphonylurea's long track records introduced in Western countries towards the end of the 40s, in our countries in 50s. High HbA1 lowering effect, about 1.5% when compared to other oral anti-diabetic agents, and UK PDS had shown that there is no cardiovascular toxicity of sulphonylureas when given over a long term, and vascular benefits have been documented in advance on trials and steno-2 trials, but in this case specifically with glyclazide, not other sulphonylureas. So safety and efficacy in prevention of vascular complications has been proved in UK PDS trial and advanced trial and steno-2 trials and a long experience. Now I told you about cost of therapy. Consider this, 33% of world's poor live in India and 33% of Indians are below the poverty line. Poverty line is defined as a person who is earning less than 60 rupees a day. And the daily cost of DPP-4 inhibitors is 45 rupees, daily cost of SGLT2 inhibitors is even higher. So considering this, sulphonylureas are still the mainstay of treatment of diabetes in our country. This bar chart shows you cost of therapy slightly higher than metformin, much lower than insulins and the modern drugs. Of course, modern drugs do not produce hypoglycemia, but everybody with sulphonylurea doesn't go into hypoglycemia. Modern drugs do not increase the weight, but everybody with sulphonylurea, particularly sulphonylureas like glyclazide, do not get significant weight gain. Because if you avoid hypoglycemia, you avoid weight gain. Anyway, now let's see how the even advanced countries are still putting sulphonylurea on board and offering the choice of sulphonylurea in certain situations. How do they individualize? They say if you want high efficacy and if you want it to be very cheap and cost effective, select sulphonylurea. If you want to fight the insulin resistance, you select pioglitazone. If you do not want weight gain, if you do not want hypoglycemia, and if a patient can afford, you go in for DPP-4 inhibitors. But there DPP-4 inhibitor is not as strong as sulphonylurea, slightly milder, slightly weaker, slightly less reduction in HbA1c. If you want to reduce weight, not only prevent weight gain, but to reduce weight, you don't want hypoglycemias, you are ready to spend more, then you can consider SGLT2 inhibitors. There are new kids on the blocks. They have certain advantages. If a patient can afford, they are good drugs. But there are certain patients who cannot tolerate it, particularly females who get genital fungal infections, urinary tract infections. Some of the Indian females just cannot tolerate SGLT2 inhibitors. They have so much severe pruritus and that you can't use them. But if you don't have these problems and if you have money, these are good drugs. I already talked about GLP-1 analogs. They are niche drugs. 8,000 rupees per month is very high for Indian standards and injectable. And insulin, of course, works in every patient, but as far as possible, patient would like to avoid it because of inconvenience of injection. So what do the Americans say even today in 2016? If you want to economize the cost of therapy and you want a strong drug, you can still consider sulfonylurea. Now, we have thoroughly considered when sulfonylureas and why sulfonylureas. Now we will enter the discussion into which sulfonylurea. Now we have 4 sulfonylureas available in our countries: glimepiride, glipizide, glyclazide and glibenclamide. Now every sulfonylurea is different. Don't consider all sulfonylureas to be similar, even though they have same mechanism. Pharmacodynetics of each sulfonylurea differs from each other because their ability to combine with receptor is different. Say for example, glyclazide and glimepiride are more specific in the sense that they act on sulfonylurea receptors on the pancreatic beta cells, but they act on receptors situated in the myocardial cells and sulfonylurea receptors situated in the vascular smooth muscle cells. Now, what happens is, whenever a patient is suffering from ischemic heart disease or ischemia, he requires that sulfonylurea receptor should not act on myocardial cells because that prevents recovery from protective effect of sulfonylureas on myocardium, a protective effect of ischemia on the myocardium. So, the drugs which are specific for action only on pancreatic beta cells like glimepiride and glyclazide are superior as compared to drugs which are non-specific like glibenclamide and glipizide. So, in other words, after having decided that you would use a sulfonylurea, glyclazide and glimepiride are better choices than the other 2 sulfonylureas if a patient has a heart condition. Now let us see mortality and cardiovascular risk associated with different insulin secretagogues compared with metformin in type 2 diabetes. Even though not conclusively proved, many people believe that sulfonylureas are not very safe from cardiovascular point of view. They are not as safe as DPP-4 inhibitors or SGLT2 analogs in the management of type 2 diabetes, particularly if the patient also has cardiovascular disease. Of course, nobody has proved it, but there are certain statistical data is available like this particular work which says that cardiovascular mortality and risk is increased by all sulfonylureas other than glyclazide and repaglinide. But repaglinide is not essentially a sulfonylurea, it is a milder drug which is known as glinide, which acts like a sulfonylurea but which is not chemically a sulfonylurea and which is not really a competitor for sulfonylurea. It is better for postprandial blood glucose but not good for overall reduction of HbA1c. So from a cardiovascular point of view, this data tells you that if you want to avoid the mortality and morbidity, a slight increase in mortality and morbidity which is associated with use of sulfonylurea, select glyclazide because it is the safest sulfonylurea from cardiovascular point of view. And why it is safest sulfonylurea? Because of it is the selective nature of its combination with the sulfonylurea receptor. In short, it combines with sulfonylurea receptor in the pancreatic beta cells which is desired and which releases insulin which reduces blood glucose, but it does not interact with a sulfonylurea receptor on a myocardial cell, particularly a sulfonylurea receptor in a mitochondria of myocardial cell, and this adds to the safety. Now, as I have told you that two sulfonylureas are safer from this point of view, glimepiride and glyclazide. So let us look at the efficacy as regards ability to reduce HbA1c. This slide tells you in a clinical trial reported in European Journal of Clinical glyclazide was slightly stronger as compared to glimepiride as regards its ability to reduce HbA1c. Now the second problem which you want to avoid when you are treating the patients with sulfonylurea is hypoglycemia. In this particular work, again reported in the same, that is investigations, the prevalence of hypoglycemic episodes in those exposed to glyclazide, comparative prevalence and glimepiride, 3.7% of the patients on glyclazide and 8.9% of the patients on glimepiride had hypoglycemia. So if you want to avoid hypoglycemia, if you want to reduce the hypoglycemia, then glyclazide is a better drug than glimepiride. And in elderly persons with cardiovascular problems, hypoglycemia can sometimes even be fatal. So you have to go all out to avoid hypoglycemias. And in this condition, glyclazide is a clearly better drug as compared to glimepiride as regards hypoglycemia. Far lesser episodes, statistically significant lesser episodes as compared to glimepiride. Now this slide tells you the prevalence of hypoglycemia not only with different sulfonylureas but also with sitagliptin. As you know, all gliptins are considered generally very safe from hypoglycemia. Now if you compare the hypoglycemic episodes of sitagliptin and glyclazide, they are the same, lesser than glimepiride and far lesser than glibenclamide. And that's the reason why glibenclamide is going out of the favor as on today, particularly in elderly persons, particularly renally impaired patients, because far higher episodes of hypoglycemia with glimepiride as compared to glibenclamide as compared to glyclazide. Glyclazide is as safe as sitagliptin as seen here. You know, when Muslims observe Ramzan once a year, where they have a fasting for prolonged time in 1 month, continuously for 1 month, and diabetic Muslim patients also observe Ramzan, and then they are more prone to develop hypoglycemias. And in this condition, sitagliptin is considered as a very safe drug. It has a patients on sitagliptin have lesser episodes of hypoglycemia as compared to general with sitagliptin. The hypoglycemic episodes are more or less same. So glyclazide is as safe as sitagliptin, which is generally considered very safe to use in Ramzan. So glyclazide is a potent sulfonylurea, even slightly more potent than glimepiride, which is obviously considered as a potent sulfonylurea. Less hypoglycemia as compared to glimepiride, but in addition it also has a solid proof that it has a vasculoprotective effect. In advanced trial where glimepiride was used as a preferred sulfonylurea, the prevalence of micro and macrovascular complications were lesser as compared to other agents, and most of these lesser complications were due to a predominant effect on renal complications. What about the beta cell exhaustion? It is generally believed that sulfonylureas cause beta cell exhaustion, and that's why they are effective for a shorter time as compared to other drugs, particularly newer drugs. But there is a lot of controversy about it. Nobody has proved about it exclusively. And if you look at the advanced study where the glyclazide was used over a long period, and then advance on study, which continued for more than 5 years after the termination of advanced studies. The patient continued to have good HbA1c, meaning they have had at least glycoside as a long duration of action. This slide gives you a comparison between glycoside and glimepiride. Glycoside is at least as good as glimepiride, if not better, as regards its ability to reduce HbA1c. It is safer as regards prevention of hypoglycemias, and it has the vasculoprotective effect which has glycoside. Even the risk of mortality is also lesser as compared to glibenclamide. As if you compare glycoside as compared to gliptins, glycoside is more potent as compared to gliptins. It is available for a longer time. It has a vasculoprotective study. Most of the gliptins do not have vasculoprotective study. They are proved to be safe but not beneficial. And glycoside also is reasonably safe from hypoglycemia point of view. And if you avoid hypoglycemia, you reduce the weight gain problems which is associated with sulfonylurea. So in short, yes, sulfonylureas may not be ideal medicines, but there is hardly any medicine which can be defined as ideal medicine for the treatment of type 2 diabetes. Nothing is ideal in the real world situation. The alternative patients come with their own problems. However, the experience in sulfonylurea is immense. They have to test at the time. They are very cost effective, which is a very important thing in a country like India, which houses 33% of world's poor. It is strongly recommended by the Association of Endocrinologists of South Asian countries. Sulfonylureas have ability to lower HbA1c, which is better than some of these modern drugs. And what is more important to remember is that not all sulfonylureas are similar. Glycoside is definitely a better sulfonylurea as regards hypoglycemia, as regards CV safety, and at the same time, it is as good sulfonylurea as any other sulfonylurea as reduce HbA1c. So glycoside is a good add-on drug to add to metformin when metformin alone is not sufficient in the management of type 2 diabetes, particularly. Patients have to be chosen. Individual patients have individual need, and just like horses for courses, sulfonylureas are more suitable for Indian diabetes. Place of sulfonylureas in therapy of type 2 diabetes. I have given you a balanced and patient-centric approach, not a pharma-centric approach, not a CSU-centric approach, but a patient-centric approach. Individualization is the key. Thank you.
We have got some questions, or if you would want to take that. Should I move it to the center?
Dinesh asking me that how glycoside is better than glimepiride as regards the action or the safety on cardiovascular system. The structure of glycoside and glimepiride is different. Both these drugs are safer as compared to older sulfonylureas like glipizide and glibenclamide, because being a different structure, this structure is not suitable for a combination with sulfonylurea receptor on the myocardium. These two drugs do not combine with sulfonylurea receptor on a myocardium. They are safe. Theoretically, both of them are safe. Practically, the statistics. It has a lesser mortality as compared to glibenclamide and glimepiride, and also glipizide. And this is because of its specific action only on sulfonylurea receptor in pancreatic beta cells. Vijay Kumar, can we get rid of sulfonylureas in the era of DPP-4 inhibitor and SGLT2 inhibitors and GLP-1 agonist? You cannot get rid of sulphonylureas because I told you they are potent, they are economic. Everybody cannot afford DPP-4 inhibitor, everybody cannot offer GLP-2 analogs, they are very costly, and sulphonylureas are here to stay. I showed you the guidelines issued by the IDF to the entire world, including developing countries. I showed you guidelines developed by the endocrinologist of Southeast Asia, where individualizing the patient, looking at a socio-economic factor, they are still strongly recommending sulphonylureas. So you cannot throw out sulphonylureas by any means. Now, Dr. Vijay Kumar is asking question that can we start treatment with SGLT2 inhibitors? You can consider SGLT2 inhibitors as first line treatment only in rare cases where metformin is not tolerated. The second indication to consider other drugs than metformin is where there is a renal failure of a sufficient degree, because of which you cannot use metformin. But mind you, you cannot use SGLT2 inhibitors in impaired patients because though they are not toxic to kidney, they are useless. The patient's GFR is less than 45. So you should not use SGLT2 inhibitors in a patient who can be put on metformin as a first line treatment. You can consider SGLT2 inhibitor as a second line treatment, but in most of the cases not as a first line treatment. I have already discussed the differences between gliptin and glyclazide. What are the differences? Glyclazide is a bit more potent as compared to all the gliptins as regards ability to reduce HbA1c. Glyclazide is almost as safe as interview, and if you avoid hypoglycemia, weight gain is reduced to some extent. But if somebody doesn't want even a stream and he can afford, gliptin may be used in that patient. In other patients, you can go in for glyclazide. We have discussed this very thoroughly. How glyclazide is better than glimepiride? Glyclazide is better than glimepiride because it is less likely to cause hypoglycemia as compared to glimepiride. It has a lesser cardiovascular mortality and morbidity compared to glimepiride, and at the same time it is at least as potent as glimepiride in its ability to reduce the HbA1c. And one more very important thing, glyclazide has proven vascular. Glimepiride does not have any specific long-term trial to prove its cardiovascular benefits. Is glyclazide better than pioglitazone? It depends again on individual patients. Pioglitazone use leads weight gain, glyclazide does not lead to weight gain. In a patient where you want to avoid weight gain, glyclazide is definitely better. It does not lead to hypoglycemia. Glyclazide leads to hypoglycemia, but not as much as other sulfonylureas. If you want to avoid hypoglycemia, maybe pioglitazone is better, but glyclazide is as good as pioglitazone in its ability to reduce HbA1c. Now, why glyclazide is better than glimepiride in diabetic nephropathy is another question asked by Surjit Banerjee. Now, if you look at guidelines, all the international guidelines say that you can use glyclazide in the full therapeutic dosage in any patient, any degree of renal impairment. As far as glimepiride is concerned, guidelines state that you have to be careful in renal impairment and you have to use only half the therapeutic dose of glimepiride in renal impairment. Don't go up to the full therapeutic dose. You use half the therapeutic dose. So there are some restrictions on use of glimepiride in diabetic nephropathy, but there are no restrictions on the use of glyclazide in diabetic nephropathy. Differences or comparison with glyclazide and gliptin, I have already discussed. It has to be individualized depending upon patients. Glyclazide slightly more potent, slightly more likely to cause weight gain and hypoglycemia, but not as much as other. Which is the best combination with glyclazide is the question of Mr. Chakravarti. The best combination today is metformin glyclazide, obviously. Is there any other question? It's not going up now. So, in short, we have seen the current status or current position of sulfonylureas in management of type 2 diabetes in India in 2016, and after having defined the position of sulfonylurea, we have seen which is the best sulfonylurea, and to the best of our ability we have answered the questions put forward by many of you. Thank you very much. I hope you will be benefited by these interactions. Thank you.
On behalf of you attending the webinar, thank you so much and good night.